good afternoon by 15 seconds. Have any of you got a medical complaint? Hands up. Okay, well, I'm not Charles and Leslie, so you're stuffed. Okay, so basically, he's gone AWOL because he's been summoned to a very important meeting at NHS England. My name is Roger Hymas. I gave the last presentation in this room, and they came up to me and said, will you hang around and be chairman of the next session? So by way of introduction, I run a company called Health+Care Commissioning Services, and we essentially built the Innovation Pavilion. We've brought everybody together, all 18 CSUs, into what, of course, is the first trade show for Britain's biggest new £1 billion industry commissioning support. So thank you for coming. We have three distinguished representatives of that industry who are going to talk on this particular theme. But before we start, I think they would probably like to know how many of you work in CCGs? Oh, that's going to be easy then, isn't it? How many of you work in CSUs? Oh, that's going to be even easier for you. And how many of you, like me, are trade? Okay, right, very good. Well, we're going to go not in alphabetical order. We're going to do tallest first, which is Derek, and he's going to lead off on the theme, how can CSUs gear up to deliver transformational change? Each of them are going to speak for about 4 minutes or so, which will leave us lots of time for questions. Derek.
Thank you. Good afternoon, everybody. Transformational change. How can CSUs gear up for it? Well, I would argue that in many places we're actually involved in transformational change now. CSUs are being geared up to, and the phrase is, move from the transactional to the transformational. And our DNA is very much in the transactional in terms of the way in which we've structured our services to respond to the requirements of CCGs as we have developed over the last 12, 24 or so months. But when I look at our services, actually, in my definition of transactional, I'm not sure we do that much that is transactional. In Staffordshire and Lancashire, and similar to other CSUs, we run something called the contract management service, where staff embedded in our CCG customers work with providers on the CCG to improve outcomes for patients who are subject to the contracts with those providers. I don't want those teams to be just stating the obvious and hoping that and letting CCGs then deal with the improvement factor. I want that contract management team to be catalysing improved outcomes and improved performance within those providers. And I think where we are in the world is actually that we increase our transformational role with CCGs. And I say that in the context of and I'm sure my colleagues would never question or bring into question the sovereignty of the CCG in terms of their leadership of the commissioning process in their given locality. And so where we need to be is in a place where we get ahead of the curve, we recognise what is happening in our localities with our CCGs, but we are also conscious of what is working somewhere else, and marrying those two together for an offer to catalyse CCGs into a different world in terms of transforming the services around them. Because CCGs, the transformation for me, for CCGs, is about how do you continue to improve health outcomes with at least, best case scenario, flatline cash, potentially lower funds. So the transformational piece is helping CCGs into the space where they can deliver on outcomes and deliver on finance at the same time. My final piece in terms of how do we gear up is we gear up by being agile in our operating model. We do not employ and will not employ strategic change managers, strategic change commissioners on a full-time 12-month basis, because there isn't the revenue to support it on that basis. But what we will do is build a network of strategic partners who bring different skills to the table and lead the provision and lead the projects utilising those partners. So for me, transformation is here. For me, transformation is about helping CCGs to the place where they need to be, whilst recognising that they are the commissioning leaders in their given localities. We have examples of what we've done in Lancashire in terms of a Lancashire-wide clinical redesign approach, and there's a diagnostic tool that has just been used with all our clinical commissioning groups in Lancashire to identify what is needed to happen to deliver that transformation, and we continue to work with Lancashire CCGs on that basis. And I think that's about 3 or 4 minutes. Thank you very much indeed.
Afternoon all. I'm Tim Andrews from Cheshire and Merseyside Commissioning Support Unit. So I think firstly I take a slight issue with the title because I don't think it's our role to deliver transformational change. You know, Derek's already made that point I think, but obviously it's clinical commissioning groups, area teams and local authorities really that face that challenge. Our job is to support them where they require that and where they want us to. So how have we gone about doing that? Well, I think there's a number of layers to it. The first layer for us is that we can obviously deploy a lot of specialist resources that would be required to support a whole raft of different types of change initiatives. So whether that's procurement, engagement and communications, whether it's specialist contracting and finance support around different commercial models and funding approaches, whether it's analytical support for business case or scenario modelling, or whether it's workforce analysis and transition support. So we have within our CSU a whole set of professional functions. All of those are expected to be able to contribute to, and do, as Derek says, we're already doing this, do contribute to many aspects of the transformational agenda as required by and needed by our clients. So we've built that into the way in which the CSU is organised. The second layer is where the CSU can operate as an integrator, and I think there's 2 components to that. There is the integration of ideas, so the proactive marshalling and management of good practice and good ideas in areas that are relevant to our clients' needs. So we've done that in a systematic way. We've got at the heart of the CSU an innovation hub, which actually takes its lead from the client's own strategic plans. So we look across all of our clients' strategic plans, what they're focusing on, and then that becomes our watch list. And what the team are doing there is regularly looking at ideas to support those areas of focus that our clients have. So that's one, and now obviously those ideas come from a whole myriad of sources, and so they're not just looking at trawling the internet for ideas, but obviously reaching out to organisations to bring that in, whether that's voluntary sector within the NHS or externally. And I suppose that leads neatly to the second element of integration, which is integration of the skills and capabilities that reside externally of the CSU, because there's a huge wealth of talent both within the NHS, also obviously within the voluntary sector and in the private sector. And one of the ways in which we've sort of tried to really make a virtue of our scale is to really operate, to systemize an approach where our clients can access those additional resources to build skills and capabilities, and to bring specific elements to a particular initiative or transformational agenda. So we've got a systemised way of doing that, which makes that very effective and hopefully draws in many participants into that approach. I think the third layer for us is about supporting collaboration and integration. So one of the things that we're privileged to be able to do is look across, in our case, Cheshire and Merseyside, across 12 clinical commissioning groups, 9 local authorities, and a myriad of providers, and really see where the commonality of challenge is and where the commonality of focus is. And that might not always be geographically proximate. So for instance, in our area, there might be more a closer synergy between aspects of rural Cheshire and aspects of the top end of Sefton than there would be necessarily between the top end of Sefton and central Liverpool. So we're able to really look across that and say, actually, there are opportunities to collaborate across and over geographic boundaries. And I think linking to that, we're also looking at opportunities to how we can really help health and social care come together in a more systematic way. So of course, health and wellbeing boards exist, and they are hopefully starting to get up and running and really start to make a difference. But actually, it's a really practical level. What we're trying to do is say, if we integrate some of the core processes that a clinical commissioning group goes through and align that to the same processes that is going on within a local authority, there's a better chance actually that integration will happen. Whether that's starting with a planning phase and creating a consistent and coherent planning platform for the annual planning cycle, which we call the annual status review, or whether that's on a very practical day-to-day basis, creating an integrated reporting suite that actually spans clinical commissioners and health commissioners and local authorities. So they're looking at the same data set, they're understanding the same challenges and in the same cycle. So those are the three layers that we've looked at in terms of the way in which we can practically build on the scale and the mix of skills within our CSU. And those can be drawn on as much or as little as our clients require for them to deliver the Transformational Change Initiative. Okay? Thank you.
Good afternoon. I'm Andrew Ridley. I'm Managing Director for the Commissioning Support Unit that covers this area of London, and I briefly just wanted to talk about what we mean about transformational change, our approach to it, some of the work that we're engaged in, and some of the challenges going forward. I think it's probably helpful if I say that on the whole I am optimistic about the industry's abilities to deliver transformational change, but my optimism is tinged with realism about quite how difficult it is. And whilst people talk a lot about transformational change, including competitive tendering, or payment innovation, segmentation of the population's needs, etc. I really want to talk on about the hard yards of change, really, things that tangibly change things on a big scale for patients that either significantly improve outcomes and quality, like the stroke or heart attack reconfiguration that we recently saw in London, or significantly improve user satisfaction, or reduce costs, which is another big challenge that we have in the industry. And all of these things, in my experience, and I think the experience of the commissioning system over the last 10 to 20 years, is extraordinarily complex to deliver. It's very time consuming, and it can be enormously costly. And if you get it wrong, I think as we saw in yesterday's decision around the safe and sustainable outcome for paediatric heart surgery, the consequences both for patients in terms of delayed improvements, but cost to the NHS and avoided improvements can be quite significant. And because of that, we have three big change, about 30 or 40 people who support our customers, mainly CCGs, but also NHS England, work on transformational change. We have one that's called the Transformational Change Team. They kind of do what it says on the tin, and they're supported by a finance team who only work on financial modelling for customers of really big, complex change. And they work with a third team called the Delivery Improvement Unit, which is like an internal consultancy that helps customers diagnose problems with pathways or providers and then put together the beginning of a change process. Our change process focuses on the kind of four key segments of the commissioning cycle, really, from planning to consultation and engagement, then to decision-making and implementation, and then embedding. So on planning, we will help customers undertake evidence reviews. It's not a bad place to start, looking at the evidence, look at the options and the impact on the health economy, and do a business case, and the associated finance and activity modelling that goes with that. On the consultation and engagement phase, we'll then help manage the process of statutory engagement, which is complex and burdensome and very difficult for small organisations to do well, and the cost and burden of legal challenge is high. On decision-making, delivery and implementation, we help with program management and supporting implementation. And then finally, in terms of embedding and evaluate, we embed and help customers look back and do benefits realizations, but also critically embed with the contracting cycle and what our business as usual teams are doing, so that the finance and contractual flows sit behind the transformational service change that people have made. Just to give you some examples in each of those quadrants of things that we're doing at the moment, in the planning phase, for example, we're helping 3 CCGs have commissioned us to look at a feasibility study for them to reconfigure their existing separate inpatient mental health services. Now, this follows on the back of a piece of work we did last year, where we helped them centralise 3 separate inpatient dementia units, which were suboptimal in terms of staffing levels. Quality of care was variable and costs were disproportionately high. And we helped them centralise those services, saving the provider and them as commissioners significant amount of money, but critically really improving the quality of care for patients from a centralised unit. And we're now repeating that on a bigger scale, looking at the whole of inpatient care across 3 London boroughs. And we'll see what that feasibility study shows up. In terms of consultation and engagement, a complex piece of work that we're engaged in at the moment on behalf of NHS England and London Cancer is working across 13 London boroughs of North East and North Central London and into Essex, covering a population of about 5 million people, consulting with all the CCGs, all the local authorities and all the relevant patient groups to change a really critical pathway that affects 25 patients a year out of 5 million. There will be tangible improvements to the outcomes of that service as a result of that consultation, but the amount of engagement and change that is required to successfully enable the clinicians who are leading that service make the change that they know is in the interest of patients is significant. And in terms of delivery and implementation, we're supporting 2 clusters of CCGs implement successful acute services review. So one cluster of CCGs in this area implementing Health for North East London, which is a reconfiguration of acute hospital services in this area, big changes to maternity flows across 7 different London boroughs and 6 different acute sites, and a change in A&E pathways. And similarly, we're supporting, although it's been led by the CCG, we're providing technical support and expertise to a group of CCGs that are implementing changes in Barnet, Enfield and Haringey, which you might know more colloquially as Chase Farm changes. And if any of you doubt that transformational change is complex, costly and difficult, I should point out that we are implementing the changes to Chase Farm now. It's taken 20 years of analysis, political management and stakeholder management to get to the point of implementation, and we are still not guaranteed that they will be delivered successfully. So my conclusions are that CSUs have the scale and some of the technical skills to really help CCGs, NHS England and local authorities think about how they deliver transformational change successfully. But we need to continue to build our capability and capacity. And my observation is that this capability and capacity is rare. It's often highly technical skilled. And it is very expensive. I suspect in time, over the next 2 years, you'll see the emergence of formal partnerships between CSUs as we begin to work to bring together these kind of functions so that whichever part of the country have got most complex change going on, we can help them manage that. And I think increasingly you'll see partnership agreements between us and non-NHS providers to bring the capacity into the system to help us deliver on what is undoubtedly the biggest challenge that NHS commissioners face. Thank you.
Thank you very much. Do we have any questions, please? Yes. Who's got the mic?
Stand up. Hello, I'm Dali Jandin from QT Business Solutions. And my question is, given that Roger made a a very interesting point in his presentation around CSU's development and delivering potentially end-to-end services, and Sir Bob's presentation yesterday talking about that. And Roger's point was that you need to perhaps focus and specialise in certain areas, and I think you picked up on that, Andrew. I was wondering what the observation of the rest of the panel was.
So the question was, do you want, as a CSU, to focus and specialise, or do you feel that your challenge should be end-to-end, covering just about every single aspect of the commissioning cycle? And I guess, therefore, which are your own particular preferences, and how do you see your own direction in terms of tackling those two challenges? One, be very focused. Two, essentially become a supermarket and offer the full range of commissioning cycle services. Who would like to go first? Do we have a volunteer? Right.
I'll go first on that one. I think CSUs are in a very special place at this point in time and moving forward, because we're in a world where clearly we need to work with and satisfy the needs and desires and requirements of our CCG customers, and some of those are different and many of them are the same. I think that we need to be in a position, as I said earlier, whereby we are able to offer, either through direct delivery and direct production ourselves, or through procurement of, as I said in my piece, specialist partners to help us at a point where we might not have that capacity, but does enable us to respond to the needs of our marketplace. So I think the answer is, to your question, it is both, because it will depend upon what our CCGs want. It will depend upon how we can respond to that, and if we need to specialise, then we will bring those specialists in if we don't have them in-house.
Tim, before you answer, you made the point during your part of the presentation about the need to join it all together. Mm-hmm. And so it could well be that as you actually create an end-to-end solution, that there's a huge premium on the skills of actually being the architect and the engineer who can bring that. So you might want to develop that as you answer, although I'm not putting words in your mouth, of course.
No, I mean, I think from my perspective, I think it would be dangerous to think that much of what we do is the sort of thing that you could ship off to a big shed somewhere and have delivered remotely. I'll give an example. There are certain aspects of business intelligence which you can obviously do at scale, but the part of the benefit that we're able to deliver and the inherent efficiency within our environment for business intelligence is the fact that we're able to move analysts about at different phases of the monthly cycle. So, for example, last week, most of the analysts, 80 or so within our organisation, were working collectively to deliver a whole set of reports from the data extract end to the first cut analytics. This week, you won't find an analyst anywhere to be seen within a CSU environment because they're all out in CCG land. The following week, they'll probably be back in the centre working on projects and programmes that they can do once for a number of CCGs. So there becomes a certain geographical challenge to that if you kind of went too uber big. And there's not many areas where actually it's about, I think, the creation of a kind of a traditional outsourced shared service environment. I don't think we do much of that. But I think where we definitely can specialise is in terms of some of those areas where, for instance, around systems and technologies, Derek might have a better solution in relation to some of the support systems. Why would we recreate that? We would buy that, we would share that across multiple CSUs. I think ideas integration, as we've talked about, as Andrew's alluded to, so maximising the scale by collaborating closely across a national footprint rather than just integrating ideas from a Cheshire and Merseyside or a regional perspective. So I think that is the direction of travel. I also agree that I think it's imperative that local CSUs are able to provide, as much as their clients want it, an end-to-end service, even if it is via bought-in services. So I think all of those things are probably the direction of travel, but I don't see, that big shed model really being applicable to much of the work that CSUs do.
Thank you.
Can I just add to that? I think between the CSUs you will begin to see a degree of specialisation, and you can see that already in some areas. Some CSUs are much bigger suppliers of some things than we are. For example, a huge supplier of business intelligence, not just to our CCG customers, but to 2 regions of NHS England, whereas other areas we're less interested in bidding for. So I think the supply market will evolve over time. On the core, what I would call the kind of integrated core of contracting, finance, analytics, and managing change, transformational or otherwise, I would be very cautious about splitting those out. And I'll give you one tangible little example that I think of how complicated some of the finance and activity in the industry gets. We were moving 2,000 berths on behalf of 7 customers from an acute trust that was required to do so because of a CQC inspection. It's quite a complex task in itself to move it to another 6 hospitals, most of whom are already operating at near capacity. So quite a kind of technical exercise. One of the trusts that we were moving berths to, we, on behalf of their CCGs, had essentially a block contract with an exclusion clause that any planned change in maternity flows, for example, would result in greater payment. They sought to trigger that clause. We, because we run the data systems, were able to analyse that, and we actually found out what was really going on was they had a significant and unplanned increase in their birth rate. And so their increase in activity wasn't necessarily related to the planned strategic change. That's just a small example, probably running to several millions of pounds, of how complex some of these issues can get. And my worry is if you segment out the contract management and the analytics and the finance, we'll end up spending a lot of energy with different suppliers arguing with each other about the interfaces instead of solving the real issues and getting to the underlying issues.
Thank you. A couple more questions.
First time the HSK
I'd like to ask, if I may, just one question because I can't see any more out there. If you had to choose just one thing that we're now at the very point of externalization, and you've got to say, right, well, I'm going to go forward for the next 5 years running this business outside in the commercial market. What would be the one thing, having been brought down to that, the one thing that you would decide to specialise on? Totally hypothetical question, but it's sort of if you had to choose to do the one thing within commissioning, what would you choose to do? Andrew, he's nodding, so he can go first.
So for me, it's quite straightforward. It's transformational change. If we don't, the NHS is going to go bankrupt.
Right. So you're right in service configuration.
Yes.
Right in the nitty-gritty of that. Okay.
And I wouldn't disagree with that and wouldn't add anything to it. It is the future.
Right.
It is the future.
I'd like to be controversial and disagree.
Please, but this is what this is all about.
But no, I would agree with that. I think the ability to deliver that is critical. I think the ability to decouple it from the day-to-day management and monitoring of the system you're trying to change is impossible. So it's a bit like cake and eat it, but I think by specialising in focusing on transformational change, you have to specialise and focus on the performance monitoring and management of the environment you're trying to change as well.
Okay. Oh, we have a question. Thank you. Very last question. We have time. Yes, Goff?
So my name is Michelle Mikis from PricewaterhouseCoopers. This is really concerning about being partners with non-NHS organizations to be able to deliver transformational change. So when you're externalized and you're able to go out to the market, what kind of skill sets do you need to be able to create those kind of partnerships and be able to add value to your CSU?
I think it's an impossible question to answer in one sense. It all depends on the nature of the change, and although the challenges are common, the solutions are different in every different environment you operate in because of politics, the provider landscape, etc., etc. It's all very different. So for us, on a really practical operational level, it'll be about what capacity we've got and where that capacity is being maxed out. Where do we need to augment it, or particularly where there is a specific set of skills that a particular situation throws up the need for. So it's really very much a case-by-case kind of analysis from our perspective, which is why we've developed the system we have, the flexible resource pool, which gives us the ability to rapidly access a whole raft of different skills that we know ultimately we're going to need across a range of transformational initiatives.
I'd add to that slightly, a couple of points I think. The CSU autonomy from the NHS England, although remaining integral within the health service and what the health service seeks to do, is not the tipping point for us building these partnerships with the private sector. We want to get on and do that now. I think though what we need to develop are partnerships that work more on a risk and reward basis than maybe on a daily rate type basis, which is where we are now, which gives us, I think, the opportunity to create true partnerships and gives us the opportunity then to take account, as Tim has said, of those skills or capacity that we may be missing at a particular point in time, depending on exactly what we're seeking to do at that particular time.
Just building on Derek's point, there may be occasion when we need specialist skills. My observation is that we have been building in-house capability quite significantly. We've got an internal consultancy, we've got quite high-end analytics, we've got quite advanced modelling because of the acute reconfig work that we've done. So for me, it's I don't want to sound arrogant because I think some of the big firms do bring in real skills sometimes when you need them. For me, it's really more an issue of capacity. What the big firms are able to offer, which we can't because they carry spare resource, is you can phone them today and have a team of 6 people arrive on Monday. So I think we'll be looking for capacity partnerships. I think the deal is going to be that we're going to be looking for a different economic model for our customers so that they're not paying the traditional day rates that the big 6 have charged, and that they'll good time for a commercial break. They'll get a much better deal by contracting with us, and we'll subcontract with you.
Okay, right. Thank you very much. Can we thank our presenters for their contribution today? Thank you.